All right, let's do chapter 11. All right, so this one was all about posture, coordination, balance, and gait, and how those are different in older adults. I've got a picture here in a second that'll show you what all these look like, but there are a lot of different postures for elderly people. These are very important to know and to recognize, because if someone is complaining of neck pain, back pain, whatever, it's probably due to, at an older age, arthritis or poor posture and positioning. That's something extremely difficult to treat and to help. You can do a lot of education, but overall, I mean, how easy is it for me to tell you to change your posture and for you to keep it that way at a young age? Now you do that for 60, 70, 80 years at that same posture, and there's a deformity of some type there. Okay, change it. It's not really, it doesn't have a lot of great carryover. First one is a flex posture. I'm going to show you what a picture of that looks like in just a second. You have a thoracic hyperkyphosis. This is like a forward head position. I'll show you what that looks like too. Many older adults develop an altered thoracic curve. This is a flattening or exaggeration, rounded shoulders, and flexed hips and knees. All of these can cause muscle weakness, decreased range of motion, a loss in spinal flexibility, and vertebral compression fractures. Does anybody know what a compression fracture is? Don't overthink it. From the pressure. So a poor posture, and after they have this kyphosis, which is this bending, it's putting pressure constantly on a vertebrae or group of vertebrae that it was not intended to do. Now, vertebrae are intended to have that straight, slightly curved spine and take pressure that way. Once you curve it in, it's now taking pressure in a way it was undesigned for, and it can cause compression fractures. Even younger people can have compression fractures from poor posture. That's why they preach it, or used to preach it anyway, from elementary school on, is have good posture, have good posture. Compression fractures are common even in younger people, and even more so in older. All right, so these are what they look like. Some of the common ones are sway back. I didn't mention that one, but it is a really common one. They will sit with their back kind of in extension, makes them at a massive increased risk for falls. Here's a lumbar lordosis. How many people have seen the little elderly lady at the grocery store pushing her buggy and has that posture? That's super common. Very, very common. Thoracic kyphosis. How many people have seen this one before? Where it almost looks like their head's coming out of their chest when they get really, really bad. And then a forward head. You'll be hard pressed to find an elderly person that doesn't at least have one of these. The forward head is even common in people that have tried to maintain good posture for the majority of their life. One of the examples are veterans. That's kind of ingrained in them in the military, is good posture, how to hold themselves. Even they later in life will get that forward head, and that's just from gravity pushing down on them for so many years. And lastly, that's what good posture looks like. Some age-related changes to the nervous system is cerebral atrophy. It just means a loss of brain cells over time. This results in increased cerebrospinal fluid space in your head. And then specific neural loss, that can be from a lot of different things in a lot of different areas. It's very individual based. And then a reduced dendritic branching. It's a fancy way of saying that those pathways I keep preaching to you guys, these neuro pathways, they don't make them as much, and they don't make connections as well. Okay? Am I going too fast? You cool? Okay. Let me know if I need to slow down. Some other ones are a decrease in the effectiveness of neurotransmitters. It's just not sending, signals as well. Reduced cerebral blood flow, diminished glucose utilization. Your brain uses a ton of glucose, like a ton of glucose. Trying to your brain and your stomach use most of the nutrients from your body. Whenever you digest something, it gets turned into glucose. The first place that goes is the most important part, the brain, and then your stomach also burns a lot of it while it's trying to do digestion to send it to the brain. That's why you don't see, someone might feel better and you might not be as foggy headed. Like if you ever skipped breakfast and you go through a long day and you get later in the day, like, well, I haven't ate, and you're really tired, brain fog. It's hard to focus on things, but as soon as you eat something and get that, start digesting, it's like you almost perk up. It's like you got a second wind. That's because your brain was starving for glucose. It needed that from your body. And then lastly is the alterations in the electroencephalogram. That is just a scan that they do for brain activity. You ever seen them where the scan of their head and it shows different things lighting up in different colors? That's what that is. Some causes. What would cause these changes in the nervous system? Biochemical in the neurons and receptors, a loss of neurons, decreases in the myelin. Let's do a little anatomy review. What's the myelin? The sheath that goes around, right, these pathways and things. So what that does is more or less protect and help speed it up. I like to think of it as almost like a blood vessel. This is how helps me remember how it keeps that tight, so when the signals and electrical signals shoot through, they don't get damaged and thrown off to the side, and we get good information. Defects in protein synthesis, wear and tear, just normal wear and tear on the body, and then vascular changes that we've already talked about. So what are some consequences of all these nervous system changes? An altered gait. People, when they get older, tend to walk. I know we've talked about this being slower, but they walk differently. They may walk with their feet turned inward, outward, and that may be for several different reasons. It might be that they're not sending signals good enough. As far as the nervous system is concerned, it might be because of pain from the nervous system. They walk on their feet a certain way. Think about the gout stuff that we talked about in 207, that they might walk, not on their big toe. There's a lot of things that can happen. But as far as the nervous system is concerned, it could be pain or just not getting a good signal. This is an increased fall risk, impaired sensation. But I want you guys to remember that these consequences and how well they adapt to these changes is very individual. It's all about how the person adapts, who the person was, how they lived their life, all those kind of things. One thing that goes down is postural control. These are some definitions that are important for you guys to know. Postural control is your ability to control where your body is in space. So this is not the awareness of where it is in space. This is you being able to do it. Saying, I'm going to sit upright in my chair, slightly slunched over, taking notes. You are controlling where your body is in space. Gravity is not pushing you down into the floor, all this stuff. You're able to hold yourself up. Postural orientation is knowing where it is. Okay. What else does that sound like? What other skill? There you go. Good job. And then lastly is postural stability. This is your balance. So postural control is being able to control where your body is in space. Postural stability is being able to balance that. These all coincide with each other, though, and there's lots of different systems that play a part in each one of these things. If one thing is off in the nervous system or circulatory system or whatever it may be, it's going to throw off your posture. One thing that is a big player is the slowing of the hand and eye control. Being able to, that depth perception, fine motor stuff, all of that, being able to see the fine print or that you're touching something that's dangerous, all these other issues. Decreases in hand and foot movements, decreases in motor coordination, and dexterity. Dexterity, again, is that fine motor coordination. So what are some typical changes in gait? What do we start to see? A decreased step length. How many people, older people, do you know that are taking big, long steps when they walk? They're not. Very short steps. And that's the same thing with the stride length. They're not swinging their leg as far. Slower walking velocity, a decreased cadence. Cadence is just kind of a definition for how many steps they take in a minute. Decreased ankle range of motion, decreased push off with their toes, increased double stance time, meaning, do you guys know what a double stance is? Where they stand side by side, where you're just standing upright. There's a decrease in between. When you're walking yourself, you don't stand with both your feet side by side and then take a step and then take a step. That increases when both feet are together. That time increases, makes them walk slower. And then decreased displacement of the center of mass, meaning that where they may have one of those kyphosis that their center of gravity is off, right? Okay. Are we good? Do I need to go back to that one? I saw you're still writing, Lindsay. You need a second? It's cool. I can slow down. It's fine. Tell me. I cannot slow down if you guys don't tell me. Okay. All right. So how do we assess these things? We're going to measure their range of motion. We're going to see what their flexibility is like. We may measure their strength, coordination and balance, all of these different things. The two that I want to mention that are on that list is the anticipating or the anticipatory postural control and the reactive postural control. This is where you go up and you tell somebody, hey, I'm going to nudge you. And they are preparing for that. They're not going to lose their posture or lose their balance. Reactive posture control is where you don't tell them you nudge them and they're still able to do that. Okay? And both of those are listed in your book too. That goes into a little bit more detail on how those are done. Okay? And then, of course, their gait. We're going to see what their gait is like. Now, that's probably going to be left up in the normal world, probably going to be left up a little bit more to PT. And, that side of it, they're going to measure more on the gait and stuff like that. But we have to know when someone's gait is off in order to help them more, right? We need to understand what a normal gait looks like, if they're slowing down, if they're increased fall risk, all of that stuff. All right, so what are some of the assessments that we do? Goniometry. Just simple observation, seeing and say, oh, that person's walking at a much slower rate. They're not getting their foot up, blah, blah, blah. Just simple observation, okay? There are a few that I'm going to show you guys on the video here. There's the sit and reach test, the back scratch test, MMTs, the manual muscle, the brake test, which is like a muscle brake, and I've got a video for that too. The dynamometer, what's that measure? In what? Yeah. In their hand? Yes, in their hand. And then the tug test, the timed up and go. All right, let's see. This one's probably a review because you guys did that in 209, but.
The timed up and go test to assess fall risk in the elderly population.
You never know how loud these things are going to be until they play.
The timed up and go test has been rated both 87% sensitive and specific in identifying elderly who are at risk of falls in a small-scale study done by Shanwei Cook et al. In the year 2000. To conduct the test, you need a chair, a stopwatch, and some tape to mark a line on the ground 3 meters away from the chair. To conduct the test, have your patient sit in a chair with possible walking aids at hand. Then explain the procedure to your patient as follows. When I ask you to start, please get up from your chair and walk at a comfortable and safe pace to the mark 3 meters away from you. Cross the line, turn around, and return to your chair and sit back down again. Could you repeat that to me? If your patient has understood the process, ask the patient to start the test. Once you ask the patient to start the test, you will start the stopwatch and only stop it until the patient is seated again. Okay, Guy, you may start. The patient is allowed one practice round and one round is timed. Amongst other risk factors, such as history of falls, poor vision, or certain medications, a time of 14 seconds or more during the timed up and go test, or if your patient appeared unsteady, could indicate a higher fall risk. Okay, if you're interested in...
Okay, that one's pretty much a review. You guys remember how to do that one? All of these are going to be fair game on practicals too, so just remember these.
Bilaterally, I've asked for a grade book for arms out after I've done the active range of motion that are nice and tall. Then I have her hold, don't let me count. And I'm holding for a couple seconds because I want to make her work on that side. I want to see if after a second if it just gets right or not. You did. Good job. Ready now, arm out to the side. Hold, don't let me count. I do a straight arm here instead of a bent arm because I want to really see how strong his muscles are. If she were to have an elbow issue, then I would not hold her arm. So the way that it'll show you in your handout is you can come behind the patient this way, hold the leg right out, right in, down, right out. But I don't feel like I did the best mechanical advantage that way. I don't know how you do it, Jason, but I got it front. The whole here, feel it.
What is this eerily similar to? In MMTs, when you're wanting to measure shoulder breaks, there might not be a break. You know, it very well could be they have good manual muscle or good muscle strength, and there's not going to be a shoulder break. What you would want is when you do this assessment, you may want to say with a resistance of 4 MMT, you see a shoulder break or in shoulder flexion. That's how you would document something like that. Okay. But shoulder break tests are essentially MMT, just waiting for the muscle break. And if it doesn't break, that's good, right?
The back scratch test. The back scratch test assesses the general shoulder range of motion by measuring how close the hands can be brought together behind the back. The back scratch test is a measure of the senior fitness test protocol developed by Jones and Rickley, designed to test the functional fitness of seniors. Patient instructions. The subject stands and reaches one hand over the same shoulder with the palm down and with the fingers extended, and reaches as far down the back as able. The subject then places the other arm around the waist into the low back with the palms up, fingers extended, reaching up the middle of the back as far as possible. The subject tries to touch or overlap the middle fingers. The subject reverses arms to test which position generates the best result. Once the best position is determined, the subject practices the test twice. The observers make sure the middle fingers are pointed toward each other as able, and move them into the position of best alignment without moving the subject's hands. Do not allow the subject to grab the fingers and pull to increase the range of motion. Perform 2 practice trials in the preferred position, then 2 test trials that are measured. Measure the distance between the tips of the middle fingers to the nearest ½ inch, regardless of alignment behind the back. Indicate a minus if the fingers do not reach, and a plus if the middle fingers overlap. Record the better of 2 trials.
So if someone does not or does poorly on the back scratch test, what is an ADL that we're going to be worried about? Huh? Dressing? What? Why? What part of dressing would be difficult if they fail that? Taking your shirt off? How about just tucking your shirt in? That'd be another one. What's another big ADL we're worried about? Showering. Being able to wash their back. That's another one. What's another area in showering that we're worried about?
Hair.
Washing their hair, being able to do that. So if someone is doing poor on the back scratch test, you need to see how well they're performing that ADL. Are they compensating? Do they have their own way that they're washing? Most of the time, people have compensated some way of being able to do it. What is one? There's another really, really, really important one you guys aren't naming yet. What's another big ADL that's important with? Huh? Dressing, yeah. But it's not dressing, not bathing. What's another one? Toileting. Think about that. If they're failing the back scratch test and they have poor range of motion reach behind them, they're not being able to get clean. Hygiene is a huge problem there. One thing that, remember the Buckingham Buddy white thing I showed you over there that's super weird? Do you remember what I taught you was a much easier, I feel like much more hygienic? Cassidy wasn't here, so does anybody remember what I told you was a good adaptation or a good piece of equipment to use for the hygiene portion of toileting? Barbecue tongs. Remember? Stainless steel barbecue tongs. You can get it from the dollar store. You wrap the toilet paper around it, clamp it, do your thing, drop it off in the toilet. Much easier to use than a Buckingham butt wiper because, in my experience, it gets stuck to that rubber portion, and then you're just sitting there shaking it, trying to get it to come off, and it's nasty. So barbecue tongs and they're much easier to clean. You can take a Clorox wipe, you can wash them, take a Clorox wipe, disinfect them. Much easier, much cheaper, and then go to their Dollar Tree and get them. Okay. All right, let's do the sit and reach test.
Our next test is our sit and reach test. For this test, we use a sit and reach box. It's important that we anchor the box against the wall. For the demonstration today, we're going to be using a bench just to make sure it doesn't move. And when you're doing any sort of flexibility testing, in this case the sit and reach, we want to make sure that our client is physically warm. So this test should only ever be done after doing aerobic testing. The rules for using this box in a sit and reach test are pretty simple. We want to make sure that our client takes their shoes off, so that we're actually measuring their range through their hamstrings and lower back, not affected by the angle of their ankle. The second rule is we must keep their legs straight. So we want to make sure that the knees are locked out, and the tester is required to just rest their hand on the top of the knees to make sure there's no flexion as they're reaching forward. Now, the client is required to reach as far along the scale as they can, and they must hold it for a count of 3. So it's not a bounce, it's a hold. So it's important that the client doesn't actually overstretch and push to the point of pain. Now with Weston, he's already warmed up. So what I'm going to get Weston to do is put both hands on top of each other so his middle fingers line up. And I'm going to be measuring how far along the scale his middle fingers can move. Once he gets to the end point of his range of motion, he needs to hold it for a count of 3 seconds, and then he gets to release. Okay, so I'm going to put my hand on the knees. This one. Now you're ready. 2, 3, and release. Okay. Now that I know what Weston's range is, he would have 2 more attempts to try and better that score.
The way you would do it is have him sit at a normal chair. And then there's another test. Let me see if I can find it. It's called the functional reach test.
So the verb, tenacity, get up, go, and functional reach are a few common ways to measure ball risk. Given how easy it is to execute, along with being valid and reliable in research, we use a functional reach test. We suggest using it before implementing S3 and then every 30 to 90 days or so to see how it's going. We're going to demonstrate the mobile method, which allows you to do the test anywhere, as opposed to having to do it the traditional way, where a person stands next to a wall with a yardstick attached. Kind of looks like that. To set up, confirm with the person that they're okay lifting their left arm to about here. Okay, can you do that? Yep, she's good. Now, if she couldn't do that, I asked her, what can you do with the right? And let's say she can't. Now, if that's the case, we've got to do a different test. Okay? Okay, so step 1, going to demonstrate the test. Okay? So what I'm going to tell her is, you're going to lift one arm straight up, flex the shoulder 90 degrees, feet shoulder width apart, and then I'm going to lean forward as far as I can without moving my feet and without touching anything.
What is an area that's a little bit added to this that you would do with this part, with anybody? What should this woman have? A gait belt on them. You don't want to restrict them. You don't want to hold them back with the gait belt. But anytime I've done a functional reach test, I always put a gait belt on somebody because that's what you're testing is balance and reach. Okay.
With my arm or my knees, and once I feel like there, you say stop, and then that's when I get the measurement. Okay, and then you come right back up. You don't have to hold it any longer than that. Let's prepare her. So go ahead. Let's flex that shoulder to 90 degrees. Very good. Now stand up really tall. I'm checking her feet. I want to make sure they're shoulder width. Okay. Now I'm going to hold the tape measure up to where her third knuckle is. The third knuckle, right there. And I'm at 15. And so Anne's going to record 15. That's starting. When stand up tall again. Okay, now you see my finger out here? You're going to try to touch that finger. Do not touch the tape measure. Now, you probably won't be able to touch my finger, and that's okay. But I'm going to assume kind of a wide stance in case she does lose her balance. I'm going to watch her. Ready? Go. And then just kind of aim for my finger. I'm not moving the tape measure, obviously. And I'm watching her. Is that it there? Stop. So then I look, and that coincides with 7 when stand back up. And then Anne records 7. So you're going to repeat this 2 more times for a total of 3 measurements. You're going to toss the first measurement and take the average of the last 2. This is called her functional reach for today. Now remember, you can do this every 60 to 90 days or so. But it's a great representation, and what it means is what's happening to her fall risk over time. It should be going down, which means her functional reach should be going up.
That one's a little bit more common, especially in the OT world. The sit and reach, I've seen them do it a lot more in outpatient settings. They'll have them, and I've seen them put older people down there. I mean, it is what it is. All right, so what are some precautions when doing these assessments with people? The first thing that you need to remember is osteoporosis. If someone has these, weak bones, are you going to do manual muscle testing on them? No. The last thing you need to do is break the little 70-year-old lady's arm. There's very high potential for fracture in some of these if they have osteoporosis. Concerns about what their endurance is and what their balance is. If someone has poor balance anyway, are you going to do the functional reach test? No, because they're just going to lose their balance and you're going to create a fall risk. The last one is environmental precautions. Making sure that the area that you're doing the assessment in is safe and free of hazards. All right, so some management. What are we going to do for these impairments? Exercise, it must be tailored to the individual and the goals and their needs. You cannot, and this drives me crazy, is when a therapist, both PTAs and OTAs or across the board, have one home exercise program that they end up giving to everybody. That does not work, and you do not get good results with it. You always need to tailor the exercises per person. And what I would do in home health, because I don't have a printer with me all the time, is I did have one that I kept that it was kind of a universal one for everybody, but I would give individual instructions and mark off what, don't do this, do this. Give them individual stuff like I filled it in specifically for them. That's okay. But I've seen a lot of therapists is like 3 times a day, 1 set of 20, 3 times a day, do this, blah, 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 and keep going down. It has to be tailored for that person. Okay. And then you need facilitators. There needs to be some self-efficacy. They need to be able to do some of these things. And then last is outcome expectation. You need to have realistic goals with these people. Some barriers to this is someone may have a fear of falling or a fear of injury with an impairment. They may be not on board at all with therapy, which is pretty common, believe it or not. Lack of time, that could be another big issue. Lack of social support, lack of physical space to do exercise, or not have a transportation to an exercise site, especially if you want to use some kind of specific equipment. I have never taken anyone to a facility to do it. Like I have friends that are in the field that have taken patients to like Planet Fitness and done exercises with them and stuff and worked on stuff there. There's plenty of space there, but realistically, I never had time. I was always way too busy, and that takes pretty much your whole day. And then lastly is insufficient resources to either buy the exercise equipment or join an exercise facility. This is why you see these bands, there's TheraBands all the time, and people use them all the time because they're cheap. You can buy 100 yards for 30, 40 bucks, and it lasts a long time. And a lot of people's home exercise programs eventually turn into just TheraBand exercises. What do you want to include in an exercise plan? Is strength and resistance exercises. Always, they still need to be some type of functional base. So for example, if you're having a patient who is having trouble reaching a cabinet to get their dishes out or put their dishes back, that's where they're having the issue. You might want to do an exercise in shoulder flexion that helps them lift that. That's fine. But there needs to be a functional mindset with it. It's not, oh, I'm just increasing strength in their shoulder flexors. I am assisting them in raising these plates and putting them on the shelf. There has to be a functional mindset. There has to be an ADL with it. There has to be an ADL, IDL, occupation-based with your exercises. It's not just, oh, I'm doing an exercise with them. If you do that, you're being PT, and that's not what we do. It requires careful monitoring, and you may need to change it. You may have prescribed them in a home exercise program or in any type of exercise program, and you need to change it because it's too much. They're hurting. You gave them too much. It takes a lot of changes sometimes to get it right. It needs to be demonstrated to be effective in increasing strength and endurance. You need to see some type of results, especially if this is like your claim to fame home exercise program, and this is the system that you use, and you get results. You need to get that plan. The way that I did it when I first got in the field is I talked to other practitioners, watched what they did with their home exercise programs, and I got ideas and kind of built ideas of my own. And again, that's not one exercise program fits all. It was just, hey, I like this. This is the method to increase upper body strength that I like, and I'm going to stick with that for a while. Isometric and isotonic exercises are also effective. What is isometric exercises again? Huh? No movement. What's isotonic? Movement. The opposite. Very good. And then again, always include function. One common misconception is people think they have to make a home exercise program all elaborate and all this stuff. Sometimes you can give somebody, I want you to walk up the road to get your mail and back every day. That's a goal for us. That's part of your home exercise program. You walk up with assistance or whatever the safety need may be to go get your newspaper every morning. That can be part of it. You don't have to say, all right, do 10 sets of 20 with these dumbbells in elbow flexion. You don't have, it doesn't have to be that. I've done more home exercise programs with just function activities. Your goal today is you're going to get up and you're going to make your lunch today. That's part of your home exercise program. Don't get caught up in the name of a home. It doesn't have to be just exercise based. It can be a combination or whatever the patient needs. It's all individual. And then lastly, some other things that we include with exercise plans is flexibility. You need to be able to understand how flexible that they are on doing it. And then their static and dynamic balance. That's another big factor. Are you going to have them stand up and do something? You have them sit down and do something? All of that plays a factor. And then again, with balance, it needs to have some type of a functional based approach with your exercise program. Okay. All right. Let me stop the recording.